Alright, this video is going to cover the AS occiput correction for Gonstead Cervical Chair. Gonstead is one of the few techniques that actually analyzes and corrects an AS occiput. To do that, we have to use a condyle block. The condyle block helps stabilize the atlas and the rest of the cervical spine. If we attempt the adjustment without this, we can subluxate the patient or hurt them in a different area. So you have to have this block to do this adjustment correctly. The block does have a top side and a bottom side. The top side is the square side here. The bottom side is the rounded side. It has a rounded edge and it has a little notch in it for the VP. So this rounded edge sits over the shoulders. What this block will do is we slide it down right off the occiput. Once we get to the bottom of the rim of the occiput, it slides right into the cervical spine and stabilizes the cervical spine for this adjustment. And I'll be doing the same positioning on the patient. I have to keep the hair out of between the block and the patient or between the block and me. So I'll sweep the patient's hair out of the way. I'll slide that block down occiput till it settles in right under the occipital rim. Again, the hair swept to the side. I'll have to position myself to stabilize the block against my abdomen. And for this correction, I'm going to use, I have two contact points. I have either the glabella for a straight AS correction, or I can use the supraorbital ridge. If we have an AS-RS or an AS-LS listing, I can move the segmental contact point to the supraorbital ridge. I prefer that because it gives me a little extra leverage to go the lateral to medial with that component. We also have three contact points. We can use our pisiform, our 5th MCP, or our 3rd and 4th PIP joints. We have to overlap like contact. So if I use pisiform, it's pisiform over pisiform. If I use 3rd and 4th MCPs, they wrap over each other as well. So I have the patient back against the block. We have to make sure that we preset the patient into a little bit of a flexion position. What we don't want to do is make the contact and extend the patient over the block. So I'll take the patient, I will kind of set them into a little bit of a flexion position. I'm going to take my 3rd and 4th MCP, S to I tissue pull, back it up with the tissue, back it up with stabilization on the other side. My elbows are going to stay in nice and tight by my side, so I have an S to I orientation from my hands through my elbows. And when I make this adjustment, it's a little bit of a scooping motion. I'm going to bring the patient to tension, and then I'll do a scooping motion. I'm not going to demonstrate on the patient because I actually have a pretty good lever on that with stabilization back here. Hold this for 1 second. So what that motion looks like is I have the patient in, bringing retention, and it's a scooping motion by pulling my elbows back and doing a little scoop with my hands like this. Okay? And just like we did on the atlas and the PS occiput, if we have an AS, RS, I'm going to move over to supraorbital ridge. AS, RS, I lateral flexor to the right. AS, RS, RA, rotator 5 degrees towards me. If I have an AS, RS, RP, I rotate the patient 5 degrees away from me, maintaining the supraorbital ridge segmental contact. Again, this is a scooping motion. This is one of the few adjustments in Gonstead where we're actually not contacting the segment that we're adjusting. Obviously, our segmental contact point is the frontal bone, and we're adjusting the occipital condyles. So we do have a little bit of a long lever. So when I do this correction, I do the impulse, it's a very controlled impulse. I want to bring the patient to tension and give a nice, crisp, measured impulse. Remember, we're using very large muscles, our lats, to pull down on this one, and we're trying to adjust a very small joint. So we have to be cautious on how much impulse we put into this one. It's a very good correction. We don't get a lot of AS listings, true AS listings, but when the patient does have one, they usually experience quite a bit of symptomatology, and this is a correction that can take care of it. That's it. See you on the next video. For the motion palpation for an AS occiput, we use the condyle block just like we do for the adjustment. And the motion palpation is basically accomplished very similar to the adjustment. I'm going to stabilize the block against the patient. I'm going to preload her. I'm going to take my contact on the glabella, and what I'm going to do is I'm going to move her in the direction of A to P, S to I, almost like a reverse jaw jut. And I'm going to do that motion, and I'm going to lateral flex her to the left at different angles, bring her back to the middle, lateral flexor to the right as I'm doing that A to P, S to I glide, looking to see at what angle the occiput may be fixated. once I determine the fixation and exactly what angle it is at, that's the angle I'll bring it to make the correction. And that's how we do motion palpation for an AS occiput. See you in the next video.